Thank you, Michael. Yes, it's a privilege, and it's with much gratitude that I am here today talking about this topic, reconciliation with dying. In my contact with terminal patients, one comment that I hear most often from them is for the patients telling me that they are afraid of what may come between now and when they die. So to me, in end-of-life care, other than the most important symptom control, I think the reconciliation of dying is a major concern for our patients. Oops. Okay. This reconciliation with dying is a process where the patient has to go through the transition of living to dying. Living is like the life, the sense of self, their work, their family, their hopes, their future, and then they have to leave all that and go through the transition of facing death. Death is like a big abyss where they have to sense, they have to feel that they are entering into a sense, a void where they have to encounter the unknown, the sense of nothingness. And so it's quite a scary and upsetting transition. And it's also a kind of mourning for them to learn to, thank you, for them to deal with the changes and the losses. Changes because they are going to face, they're going to lose all they have, what they have been enjoying in their whole life, and they have to enter into a state of nothingness where they would not be accompanied by anybody, that they will be alone. And this process is not tidy, it's not linear, it's a process with many nuances. Nuances in the sense that they not only do they have to let go of the things that they're familiar with, they have to face with something that nobody could tell them what is coming, what's going to happen. And then not only do they have to worry about themselves losing everything, they have to worry about what's going to happen to their loved ones, to their family, and whether their family will be able to deal with this transition of losing the patient. And then for this, it would not end in a very tidy resolution, overcoming this transition, or they will ever recover. There's no recovery, and at the end they have to face the loss of everything. But then at the end of this transition period, there is something possibly good waiting for them, because through all this anxiety, all this struggling, all this going through the family processes, and then at the very end, there comes a chance that they would experience the biggest maturation in their life. The maturation means that they will be able, if they could work through the whole process, that they will arrive to a state of acceptance, that they will achieve some kind of spiritual opening, and they would be able to take their whole life with a sense of gratitude when they leave this life. And psychologically, they would be in a state from evolving from a state of ego-centeredness to a state of ego distance. They would not be so much caring about everything about themselves towards the end. It will be like they will feel the connectedness with with humanity, with the universe. And that would be an ideal, but it's a process that they have to go through. Whoops, sorry. Okay, and the reality of this process is not linear, it's not tidy, there are no exact stages, and instead it's very messy, and the process is a mystery in itself. And then the length of this process, it could range between a minute. Later, I'll tell some stories about people going through this process. It could range between a minute to over 10 years. So there's a big time difference between different people going through the process. And then at the end, there is no predetermined outcome, like the goal would be good death. Although for professionals, we would like to set this goal for our patients, but for every patient, what defines as good death is different, and it varies. Maybe at some time they might feel that good death is having these factors, but at other times they might feel totally differently. Okay. And then the story of a minute, the process of a minute having to reconcile with death. I heard of this story when I was teaching a class in end-of-life care just a month ago. And on my PowerPoint for end-of-life care teaching, I have this as a background. And then midway in the class, a student shared with us her near-death experience. She was on a trip with her 2 teenage children, and then part of the trip they have to get on a boat. And then on the boat there was her, and then her 2 children, and then another young woman who doesn't know how to swim. And then they got on the boat, but somehow the boat was toppled in the middle of the sea, and then she was drowning. And then as she was getting deeper and deeper into the sea, she thought to herself, what happened to my children? And then she felt that, no, it would be okay because they know how to swim. And then she thought about, what about the other woman? Because she knows that she doesn't know how to swim. But then my student had invited her to join their boat. And then she was feeling a big sense of guilt for inviting this woman into her boat. And then she realized that, and also for myself, I am getting out of breath and I'm drowning. And as she was feeling that she was beginning to drown and the surrounding was getting darker and darker, she opened her eyes and she saw this picture. She said she saw through the water the blue sky, just like the blue sky we had outside today. And the moment she told herself that I'm gonna die, when she saw this sky through the water, and then within seconds, she got a push, and then she was rescued from the sea. And amazingly, when she was rescued, she saw this other woman in the same boat being rescued, and this woman saying that she heard my student calling her name, and she was the one directed the other people to pick up my student from drowning in the right spot. And so everything she had gone through it happened within a minute, within 1 minute. And then somehow in that minute, when she got to the point of reconciling with the fact that she's dying, she got relaxed, and then she started taking in the first gulp of water, and then she was saved. Okay, that was one case, a brief case. And then another case was, I was referred to provide consultation to a family. The family, actually it's mostly to a man in his late 60s. He has been doing big business in China, in the construction business, and he was very busy there. And then his wife did not want to live in China, so his wife went to stay with their son overseas. So they were kind of living apart. And just a few months ago, the man was diagnosed with cancer, so he came back and started receiving treatment in a private hospital. And I was invited there to provide some kind of psychological consultation. But when I was there looking at this man, he was visibly terminally ill. And I could only manage to have less than 5 minutes conversation with him before a team of workers came, and then they had to wheel him off for some more investigation. And then I was left there to talk to the wife, and then the only thing I could left her with was that they could still keep up that hope, but then she has to prepare for the worst. And then I was told 3 days later the man died already. Okay, so in this case, the reconciliation, like, I don't know if there's even a minute or an hour or a few days that this man and his family would have any chance to go through this reconciliation with dying process. Because at the very end, they decided because the man had earned a lot of money, so he deserves to have the best treatment in private hospitals. That's what he deserves. But then seems like, you know, at the very end, he was still receiving active curative treatment, and he was undergoing a lot of discomfort. But sometimes that happens. Okay, and then there's a third case that I would like to share. I was doing a remembrance program in Jockey Club Home for Hospice, a remembrance program for bereaved family members. And then in the program, there was a man who shared his experience of his wife dying in the hospice in here. He was telling us, you know, like 3 days before, 3 weeks before his wife died, they were admitted to here, and then they got the notion from the doctor that the life expectancy would be between 2-3 weeks, and they begin to work on this time they had together. This man is in his early 60s, just retired, and then this man and his wife had 2 children living independently. And because the wife was from Taiwan, so she would cook some like Taiwan dishes that the family really enjoy. And then in the 3-week stay in the hospice, the man was expressing much appreciation about the wife's the culture and the special cooking that she had prepared for the family the whole time, and then they decided midway between their stay, they decided that the wife would, when she was still quite weak, gradually told the husband the recipe of doing one dish, and then the husband would go home and got the ingredients and prepare the dish according to his wife's recipe, and then he would bring back and share it with his wife. Of course, the wife was too ill for any intake of food at that time, especially the kind prepared by him. But then he was eating it, and then his wife, it gave his wife a lot of gratification that her husband was able to maintain the legacy that she had developed for the family. And in the 2 weeks, the husband managed to learn how to cook 2 dishes and brought it in and ate it in front of the wife. And then the wife died after 3 weeks stay in the hospice. And the man, when he shared his story to us, he described these 3 weeks as the nicest time in their marriage, because they felt that they're able to focus on each other. They are able to do what they really cherish as important. And he really felt the experience really had brought a very nice closure to their marriage. And he was so pleased with his wife dying in here that he started volunteering as offering free rides to any families who need to commute between the hospice and their home, and bringing in families. And that seems like a very, they did not need a lot of professional intervention, but somehow, given the right environment, given the right kind of support, with the awareness that the amount of time they had, they managed on their own to go through that reconciliation with dying. And obviously, his wife died a good and peaceful death. Okay, and then the fourth situation, the fourth story, she is a advanced stage breast cancer patient that I occasionally ran support groups for. And then this woman was diagnosed with breast cancer 13 years ago. When she was first diagnosed, it was, she had stage 3 cancer. And then 3 years later, she was told that her disease had metastasized further, and she was given an advanced stage 4 diagnosis. And for her, it was extremely difficult because she has always been a fighter. She wants to fight the disease, and she wants to stay strong. She wants to take care of her children. They are in college. And she felt that there is so much she needs to do, and there is not a chance to do it when she was given this terminal diagnosis. But given time, she came to realize that nobody told her how much time left she has. And then she realized that no, she does not need to fight the cancer anymore. She wants to learn to live with it, and she wants to prepare her children so that they would be able to, she spent a lot of time strengthening the bond with the children and preparing them in case she dies one day. And as time went on, there were, of course, a lot of, she was still receiving treatment, because now in breast cancer, there are a lot of new target therapy, immunotherapy, many treatments. So she was given many combination of treatments, and she hung on, and sometimes there were some days she got very sick, and sometimes when she had to receive chemotherapy again, she got sick, and then she lost her hair, and she had her hair grown back, and so she was struggling through that process. But in those years, her children grew, and she felt that now she's more comfortable if she had to die. And then 3 years ago, she was diagnosed with having a sarcoma in her right ankle, and she has to undergo a surgery and stay in the hospital for a few months. But she survived it, and after that, she came to realization that really death may come anytime, and so instead of worrying about how much time she got left and learning to live with cancer, she decided that something even more meaningful would be to share her experiences with other women who suffer from stage 4 breast cancer. And she went out of her way she would make home visits, she would sometimes accompany co-patients to seek consultation. And then she felt that, you know, there was a new sense of gratification when she turned the focus away from her own life to helping others. And in the advanced group now, she became very much an aspiration for other women, even though they are all in advanced stage, having advanced stage breast cancer. They really learn a lot from this woman's her beginning to really living her life in a mindful, you know, in a mindful way, living with the day and making the best use of every day, counting, like what her saying is, living today as this is the last day of my life. Okay, so the transition to dying is really, it could range from 1 minute to over 10 years. So it tells us that we all need to be prepared for ourselves and also for our patients, that there are no fixed timelines, and we could encounter this process anytime in our lives. Okay, when we healthcare professionals, when we are part of the end-of-life care team, helping terminal patients go through this transition of reconciliation with dying, what our role is, I think is very important, because it's something different from what we were trained for. Okay, like as healthcare professionals, we were trained with standardized care, evidence-based intervention, protocols and procedures, and that's all very important. But when we are helping with patients going through this reconciliation with dying, I felt we need to take on a more encompassing role, more as companions than as professionals giving intervention. As Professor Chen mentioned earlier, the spiritual care is very important, is an important part of end-of-life care. And then in a study that I did many years ago on the quality of life of patients, in the interviews, we found that like only 1/3, about 30% of people in Hong Kong, they have a religion, a specific religion, but the rest, they don't have any religious affiliation. But then in the study, we found that all of the patients, they have spiritual needs. And when we aspire to provide, because for me as a psychologist, you know, like I'm supposed to give the best psychological care for patients. But then when we deal with dying, I feel that I cannot separate the psychological from the spiritual. It always go hand in hand. And so as professionals, our role would be, as far as helping patients to reconcile with dying, we would be more as companions to walk with the patients and being in the presence of them and learn from them, and learning the individual history, their needs, and what is important to them in the dying process. And then in the process, because we are dealing with something very deep inside the patients and their families, we need to be there to make deep connections with the patients so that they would feel comfortable to allow us to get into the depth of their psyche, to get into the depth of their soul, and really let us in to accompany them during this process. And then in the process, it's not about us doing something or imposing our idea or our thoughts about what good death is, but we are there to bear witness to and to be attentive to their needs, so that we could be there to honor their needs instead of changing them, persuading them one way or another. And it's very important that we need to remind ourselves we are there to validate their experiences, to validate their pain, to validate their confusion, because in the process, they very often feel very alone and isolated. Because a lot of times, terminal patients, they feel being a burden to their family. They feel like they are a failure for not living on longer. They feel that they did something wrong, or they feel guilty for leaving their family behind, for not able to make any further contribution to the family. So they do not, they are not quite ready for the sense of, for the intention of wanting to protect their family. They are not ready to share this internal process of getting to leave the world and then face death. So it's very important for us to be there, to connect with the patients and to validate their experiences, instead of wanting to prevent their suffering, to treat their suffering, to fix the suffering. Of course, when at times when we see that the suffering were presented in anxiety or depression symptoms, we could do whatever we know to help them feel better, so that they would have more psychological energy to deal with this big transition. But then for us, it really, because when I do teaching, very often they will ask me, what's the thing that would do, that we can do that would go no wrong? What are the things that would say that would be comforting to all patients? And there's no such one thing, because there's no one size fits all strategies or approaches. Is very, so what we do, what we say is not important. Is our allowing this space, allowing the patient to go through the process in their own timing. Okay, so when we are there to accompany patients to go through this process, although we don't need to know just one thing or to say one thing that might be helpful, but then it's very important for us to be aware of the overall reconciliation needs of the dying patients. Okay, in general, we could group these needs under six general categories. Okay, to acknowledge the reality of impending death. That's why breaking bad news is important. You know, like because they need to know, you know, what is happening to them, what is the prognosis, how much time they have remaining. And then the need to tolerate the emotional and spiritual pain, because it's there. And then the need to acknowledge for the patients, to help them acknowledge the changing relationships with their families, because not only with their families, that, you know, sometimes it may be, you know, they have some conflictual relationships that they had in the past, and now it resurfaced, and they want to make amends to these relationships, to acknowledge the changing self-identity, because many patients would tell us that they don't know who they are now. They don't know their body. They don't know what they're going to face, and they are undergoing a change in their self-identity. And then the need to search for meaning, that's very important in that process. And also to create an understanding support system, because if the patient is suffering all this through themselves, and we want to include the family, but then the whole family system, and also the care community is also important, because we need to be working on the same page with the patient. Okay, we'll go through that one by one. Okay, the reality of impending death. Okay, because when understandably when the patients got the news from the medical professional that they are entering the terminal phase of their illness, it's not easy to take in, and different people have different readiness for the reality, and some are more they feel that they know all along that things are getting worse and worse, and some would not be ready to face the reality, and a lot of times we see this denial, and then like helping patients with working through the denial is always like a big thing for us, because if they are always if they stay in a state of denial, there's nothing much we can do, because they don't want to talk about that. They don't want to prepare themselves. They don't want us to talk to the family. So denial seems to be something that we need to help the patient to get over with as soon as possible, as soon as we could. But then we need to understand what denial is. Denial is like this different rate of speed. Some people are able to come to terms with the reality easier or faster than others, and then some it's just that it's very difficult for them. So if we look at the denial as struggling to embrace a frightening reality, because they don't know what coming to terms with facing death is like. So it's a natural defensive process where they feel they might need some time, they might need to sit on it longer. So denial, we need to look at denial as a state telling us the psychological, spiritual process the patient is in, instead of for our own convenience, we want them to work through this denial so that we can get on with our helping. So I feel that denial is not a barrier for us to help the patient overcome. Because sometimes everybody have their unique style of facing something very big, something that's frightening, and different people have different speed. And sometimes it's not real denial. It's just they use the kind of language. They don't want to use the word death. They don't want to use passing. They just want when I get worse, and sometimes that's good enough, because we don't need for them to be aligned with our jargon, with our line of timetable. We need to understand and accept that different people really have the different styles and different timing. And then for this, the reality facing phenomena, sometimes patients, they feel that they are getting worse, and they feel that their energy level, everything is changing. Because sometimes patients would tell me that, oh, you don't know what it's like. You feel exhausted even just lying here, and it's so uncomfortable. Okay, and sometimes patients would ask us. I have many patients who ask me, head on, am I dying? Do you feel I may die in a week, in 2 weeks? Okay, and when we are posed with that question, it's very important that we be ready to address the issue with the patients, not to answer the question, yes, you're dying, no, you're not. But then, like, take it as a signal that the patient they want to talk about this with you. Maybe they want to have some validation for their own internal experiences. They felt that they're getting weaker and weaker, and then they felt that they are dying, but there's nobody who could, they would not ask their families because they don't want to further upset their family. And when we are posed with these questions, we need to take it as patients seeking validation of their internal experiences. And then it's important that when we accompany patients in the dying process, it's very important that we tell ourselves, like, we are there to help them, at best to guide them, to accompany them, but then we need to know that the patient is the one who is there to tell us what they need, what they expect from us. And sometimes they might really ask some very straightforward questions. They just would ask us, okay, tell me what to expect in this dying process. What is it like? Is it going to be painful? Is it going to be sudden? And so when we are faced with that, we need to take it as an opportunity where the patient is ready and willing to start addressing this process. Okay, emotional pain. Okay, in the process, as you could imagine, there's a lot of fear. There's a lot of very heavy emotions, sadness, because they feel that they are leaving everybody behind. They're losing all their relationships. And there's anger because they might, even to the end, why this happened to me right now? I don't want this to happen. And then there's this sense of, a strong sense of helplessness, that they feel that they feel powerless to do anything, and then they feel powerless to even slow down or stop the process. And of course, in the process, there's a lot of fear, a lot of anxiety, and then sometimes there's confusion, and then there's also a lot of what we call the emotional and spiritual pain, the struggle, with the change and the grief entailed, and it's the pain, because the process, it signifies a grieving towards reconciliation. The patient is going through some kind of anticipatory loss, anticipatory grief, because they know that they're getting weaker and weaker, and the world is diminishing further and further, and then they know that many patients would tell me, I don't want to come to terms with this dying thing, but then I know I have to. I don't want to, but then I know there's no getting away from it. And when we accompany patients going through this process, it's very important to validate their thoughts and feelings, because terminal patients, even those who are facing death and die, they might have thoughts that we did not expect, because like I'm working with a stage 4, and she has been in stage 4 breast cancer for 5-6 years, and then she's still working, okay, and because for her, like having the income is important, and her husband is retiring, and she wanted to work, and she wanted to organize, to teach her children how to set out the family, because she's always the one taking care of the family, and then she wanted to work till, you know, not the very last days. She really want to work till she could not go into work, and we could not challenge her because that's her priority. And then of course we have patients who struggle so much that they express different desires for death. Okay, sometimes they feel that this process is too long. I'm really suffering. I've done everything. I want to die, but somehow I don't know why I'm still here. Okay, and so we might hear patients expressing many idiosyncratic thoughts and feelings and concerns, and we are there only to validate the thoughts and feelings and help them to explore, okay, what does this thought and feeling would lead to? You know, would that bring you more suffering and worries, and how do we go about, you know, like not having these thoughts as disturbing as they have been. And it's important for us to honor the pain, the spiritual pain of the patients as important and not futile. Because many patients, especially for those who express desire for death, they feel that they don't see the meaning of living on. They don't know why they have to suffer so long, and they feel that many of them feel that they are useless. They could not perform the duties at home, and they are being a burden to their family. And of course, we could be very quick to dismiss the feelings, and then saying that, oh no, it's not like that. But then I think we need to help the patient to recognize what the pain is really telling them about the process of death and dying. And then through the expression of the spiritual pain, it's important for us to make use of those interchanges to understand if there are anything that's important for the patient to not to get done, but any issues, any concerns that they want to address within the time they have remained. And then sometimes you might be very surprised to hear things that they express. Like we had one patient also from the jockey club in here, home. And he was very, very ill. I saw him a few times, and he was really, really poorly the last time I saw him. And then, and he really felt he did not deserve to die so soon. There are so many things that he had not done. And he had 2 grown children and his wife. And then while talking, and he said, he lamented that what a pity that he had contributed so much to Hong Kong, and then now the bridge, the Gongjigo Daiqiu is constructed, and he would not have a chance to use it or to even to experience what it's like going through that. And then I asked him how important that is to him, and he said it is. It is important because it would be his wish, one last wish, to take a trip to go through this bridge with his wife and two grown children, because they had not had a chance to travel together for a long time. And then actually it was doable, and we arranged a car, and then they went through the ride. And of course, it's something very, very simple. It's something that was easily arranged. And then it was what was important to him. It really signified something that he felt he deserved, but he did not have a chance to enjoy. And now he was able to enjoy this one last time with his family, and he did it. And he died 3 days later. And then, of course, this emotional and spiritual pain is, the family would witness that. They would see the restlessness, the agitation, the distress that the patient was going through. And then sometimes the family had a lot of this emotional pain of separation. So it is very important for us to help the family to live with this pain that they saw in the patient, and how to support each other, and really to help them be able to express the pain, so that by expressing it and being accepted by others for going through this pain, they might gain some insight and transformation in the process, both for the patient and the family. Okay, and then another need would be the changing relationship between the patient and others, because it's the dying and death of the patient entails a permanent separation. And then before that physical separation, they went through some, they have to go through some internal process of separation. They realize that they will be the patient realizes that they will be leaving their family behind, and then they worry especially if they have children, they really worry about the children's future, and they're saddened by the fact that they will not be there to see their children grow up. Okay, and then on many occasions, we see that when we talk about reconciliation, a lot of times it involves helping the patients to reconcile some of the conflictual relationship with others in the past, and sometimes it could be decades. You know, when that conflictual relationship develop, and sometimes is the present relationship, and sometimes the dying process made the patient revisit some of the lost experiences they had before. You know, like I had a patient, a 70-year-old man who was dying, and then but he told us that his biggest wish would be to die at home, being surrounded by his family, his wife and son and grandchildren. But then because the wife is 20 years younger, so the wife was really concerned about her living after the passing of the husband. And then I heard from the husband why it was important for him to die in the presence of his family, because he said when he was lying in bed, getting weaker and weaker, the memory of him as a little boy, 7-year-old boy, accompanying, facing the death of his mother alone, You know, it was very sad and very tragic for him as a child going through that, and he recognized that dying alone or dying without the company, without the company of family members is such a traumatic experience for him to experience as a child, a 7-year-old child, and he really could not now as he's facing death himself, he could that memory, that scene kept resurfacing, and he really felt alone and like but then in reality it could not be done. So we have to revisit his past experience as a child, and then helping the family to understand his needs, and so that they could make as appropriate arrangements to bring him home whenever they could, and then bring him back to the hospice and giving him as many home visits as possible. So a lot of reconciliation in relationships need to take place, because somehow in the dying process, many patients recall sometimes traumas in the past. Like we have another old lady who was living in an OH home, and she was having terminal cancer, and then the nurses said in home visits that she was having a lot of intractable pain, and all sorts of medicine were given, and it did not help her with her sleep and her pain. And then in the process, we gradually found that her whole life issue of not accepting herself resurfaced, because as a child, when she was 6 years old, she witnessed her brother being murdered by the Japanese army, when she was young, and then she saw her brother's body in the field, and then after that, she had to take on the responsibility of shouldering a lot of work and chores for the family. But then all this time, she felt very guilty for not as competent as her brother, and she felt that she did not provide the best care for her family. And now she's an old lady, and then the feeling that she is a failure, she did not live up to her brother's status of caring for the family, it resurfaced. And then we work with her, and then helping her to review her whole life again, and validating her experience, and also helping her to recognize what she had done for her family. Of course, now she's married and have children, but then she always had this guilt. And after a lot of work, and then one time she told us that she dreamt of her brother, her elder brother, telling her, "It's okay." And then that message, when she got that message from the dream, she felt that it was indeed okay to let go of that regret, that perception. Okay, like when we help patients to negotiate this unfinished business, this not forgiving themselves for either wounding somebody or being wounded, is very important. That sometimes the person whom they have wounded or being wounded by were no longer alive, and so a lot of times the work is an internal working that we need to help the patient to see that, like even between themselves and others, there are a lot of likeness, and then sometimes they need to recognize the differences, so that they would like revisit those past events and see the past events from the perspective when they were much younger, and recognize their own limitation at that point, so that they could learn to release themselves from the guilt that they carry, like looking at the past events from the present perspective, and then they felt that they had not done a good job. This is not, and then they had a lot of regrets. And so there's a lot of internal work that they had to go through. And then this recognizing their own relationship with their disease and infirmity is also important, because sometimes when they are disfigured, when they are losing their mobility, they need to depend on others. Patients, especially patients who used to be very strong, very independent, had taken on the role as caregiver in their lives. It's very hard for them to accept that the body is no longer the way it was, and it does not function as well as before. And then it's important for them to accept the change in themselves, and that they are getting weaker and weaker, and that it's okay to be cared for by others instead of always being a strong caregiver. Okay, another important need in the reconciliation process is a changing identity, because our identity a lot of times is tied in with what we could do, what we could contribute, and the things we have accumulated, and how we are being seen by others. But then with the disease going towards the terminal phase, is like they have to face an important question that they have to ask themselves: who am I becoming as I face this disease? Because all their lives they value their contribution, they value the sense of identity is doing something useful, doing something important. Now when they see that they are useless and burdened, sometimes it creates some kind of existential crisis, that they feel that it's no longer me. This is not what I want to see and to experience. But then this is a evolution process. It takes time for them to gradually come to terms with the gradual change in themselves, and then being able to accept that the core of themselves do not change, as the level of functioning is the role that they have taken on in the past that has changed. Of course, it involves a kind of psychological grief work that they have to say goodbye to their old self, and learning to accept that for them, they are still what they call the inner sense of themselves is still there, and not it's not demolished by the illness, although their body might be. And then in this helping them to come to terms with a changing identity, a lot of times, as Professor Chen earlier mentioned, the work, the life review process, it could be very helpful. It could be a more focused kind of work, or it could be kind of casual, where we invite the patients to tell us their life story. And then patients, it's important for them to do that. And sometimes they tell different parts of their story to different people, different segments. And sometimes they tell us, a piece that they felt as very important. Or sometimes they feel that, well, actually, they feel that what what they have done is just ordinary, and there's nothing nothing fancy, nothing major that they have done. But the fact that they would talk about that, they reflect, and then they gradually learn to find meaning, that they felt that it's okay to have my life like this. And it is that they find their own sense of dignity and their sense of integrity in their whole life story. That's very important. That they find meaning in their lives. Okay, and then whenever we talk about reconciliation, we talk about when we talk about spiritual distress, we talk about the importance of finding meaning, because when patients feel that they don't deserve having this illness happening to them, they don't deserve to have their life ended so soon. And then they feel that I've done good all my lives. I've tried to help others. I attend church. I do all good things. It's almost like in that book, why bad things happen to good people. And the author suggested that the only way we could overcome this tragedy or that that the senselessness in these tragic events is if we learn to impose some meaning in the events, that if they could make sense of, and then they find some belonging in the process, then they could find some find some comfort for themselves. And so when we encounter patients going through this process, is very important again for us to learn to tolerate, allow the patients to ask questions, to search, and sometimes to give protests, as like when they could not answer their own questions. Again, the process could be very, very uneasy. The process could be, it could bring a lot of anger, angry reactions in the patients. But it would be important for us to empower the patients to give themselves time and to put in effort to cultivate meaning for themselves. And the meaning also always has to come from them. It's sometimes we feel that it's much easier if we suggest a meaning for them, but then it seems easier, but then actually that's not helpful for patients. And sometimes when we are too ready to offer meanings, the patients will take it because they felt that since it's offered by professionals. But we need to be very, very mindful of whether we're facilitating or whether we are really out of our own need. We provide some tidy answers. Okay, so for us, when we recognize that we are in the process of helping patients go through this search for meaning, all we need to do is we as a team provide a holding environment. A holding environment meaning we try to tolerate everything that the patient is saying or how they are acting, and we help them to understand why they are saying things like that, why they are doing what they're doing, so that the patient with this within this holding environment, they would have the time and the space to find a meaning for themselves. So for us, it's very important not to give readily, give ready answers. Okay. The fifth is like, because when the patient go through that process, they go through it, and then the family need to understand what's going on. So it's important for us to help the patient to create an understanding support system. this support system could start very, very early on. Otherwise, it would be like the case where I share with you when I visit the patient who is dying, but they are still undergoing a lot of investigation, offering a lot of treatment. Like when there is no chance for the patient to talk about what is important to them, you know, the advanced care planning, the advanced directive. These conversations are very, very important. Otherwise, the burden would be on the family or a particular family member to carry the burden of guessing what the patient needs or what is most important to the patient. Especially now, many elderly in the population suffer from dementia, and this is especially important because when they lose their cognitive capacity, it would be getting more and more difficult to know what the patient really want and what their wishes are. Even just the wish for care is, and many times I heard family members who many years later, you know, they made some decision, and many years later they would regret because they felt that maybe it's not the right thing that they have decided for the patient because they never asked them, and they just guessed, or they just thought of what might be good from their perspective as a family member. So that difficult conversation, if we could encourage the patient and the family to undergo that difficult conversation whenever appropriate. Of course, you know, all this advanced care planning conversation needs to coincide when the patient is ready to accept that the illness is incurable, that there is no recovery, and that could be the time could be tricky. But then sometimes, you know, when I talk to family members, you know, like if the parent is diagnosed with a terminal irreversible illness, and then the children, the adult children wanted to ask, but then it's very disruptive to ask, you know, like out of the blue. And sometimes I would suggest for them to, you know, like when they saw on TV what's happening to some some families, or the relatives when they're going through that, is this to start a casual conversation so that the patient would start feeling comfortable in talking about what they want. Because it's not a readily given answer, because sometimes they felt that they have not thought about it, and then, you know, at one time they might thought that this is their need, and at another time they felt that no, I changed my mind, and of course it's okay for them to change their mind. So the conversation is important. And then sometimes when I run workshops for elderly, I always encourage them to think about, you know, future scenarios and take the initiative to talk about and express their wishes with the family members. Because family members always wait for the patient or the elderly to take the initiative to talk about it, because they don't want to impose. Okay, so somehow we find opportunity to encourage the patient to talk about that, and then not only to talk about that, but to inform all the family members about their wishes and their needs, because building consensus is important. We have cases where, you know, like fighting camps between family members, between children. They really, you know, like create a lot of difficulty for the care team, to the extent that we know that in some situations they hire a guard to prevent the other camp of family members from visiting the dying patients, and it's just if it could be avoided, it would be very helpful, because we need to know, the whole thing is about the patient. It's not about how the children feel about one another. And then, of course, the support system, ideally, having the patient going through receiving end-of-life care in hospices, and sometimes even in community. Some people now choose to die at home. Some people in the nursing home or OH home, there are more homes where they begin to have end-of-life care for their residents, and that's important, because the care team in the nursing home or end-of-life or OH home, they need to have this idea. They need to know what the holistic care entails, and be able to provide that for the patient. Okay, when we help patients to go through this reconciliation with dying process, a lot of it entails psycho-spiritual care. And it's very important that when we help patients go through this process, we remind ourselves that we do not automatically adopt the treatment model. The treatment model is what we are comfortable with, what we are trained to provide. Like, for example, controlling distressful symptoms and behavior, and of course, for controlling physical symptoms and discomfort is we need the treatment model. But for the psycho-spiritual issues, when the patient suffers from mood disorders during the illness process, it's important for us to provide psychological care, and sometimes psychological and psychiatric care. But then when we're talking about towards the end of life, and the patient is going through this process of disengaging from the world and needing to embrace the future of dying, it's by using the treatment model, we might not serve the patient very well. And then for us, of course, when we help patients who have treatment goals, you want to have, a certain outcome for the treatment outcome for the patients, and sometimes we might give the illusion to ourselves and to the patient that, okay, we will help them to achieve good death, when in fact we might not know very clearly what good death is, and we might not be able to achieve it because we could only be sure about the process of how we go about helping the patients, but we could not assure them of the outcome. The outcome, there are so many variables deciding for the outcome that it's important that we do not lead the patient think that, that we will help them to achieve good death. And then the quality of care that they provide, that we usually judge our quality of care by how well we have the situation controlled. Like if they undergo a lot of spiritual distress, restlessness, and then they could not sleep no matter how much sedative or sleep medication or tranquilizers they receive. we feel that we are not doing a good job. But then we need to tell ourselves is sometimes, you know, when they are dealing in the dying process, it's not just psychological. Psychological is important, but as they enter more and more into nearing death, the spiritual issue is becoming very, very important. You know, like especially towards the very end, a lot of patients would have visions, seeing dreams, seeing the past relatives, deceased relatives, and then, you know, we just cannot control these by giving them more medication or saying that it's just hallucination, because very likely they are not. And we need to be able to really take the patient's the visions, what they had in their dreams, the recurring dreams, and really help them to recognize, okay, how they make sense of these dreams, and you know, when they see that deceased relatives approaching them, you know, like how ready they are ready to go on to the next world. It's an important issue that we need to address with the patients instead of kind of just dismissing them as non-important. And when we use the treatment model, we felt that all the patients, in order to get them through the process, we felt that denials, we have to challenge the denial, otherwise we cannot start working with them, because denial, they just don't want to talk about death. And then they felt that it's the biggest barrier, but actually we need to work with denial in itself in order to better understand what is stopping them or what is hindering the patient to face that unwelcome reality of getting worse and facing death. Okay, the other parts of the treatment model is we measure how well we did by measuring how many problems we resolved. But then, you know, like the end of life, especially reconciliation of dying, there is no, there are no objective measurement of how well we do, because we need to know that patients die no matter what. No matter what we do, they die. So we could not control how well they die. We could not control that all the issues are resolved and addressed. We could only be there, be their side, and be present with them, and be guided by them, and that we are not either leaders leading them through the process, or we are led by the patients, because sometimes they don't have the energy to lead us, but rather we need to be by their side, keeping them companion in their process. Another issue is we felt that we would be doing a good job if the patient and families eventually let go, and we kind of a lot of times encourage or sometimes coerce them to let go, as if warning them, if you don't let go, then you don't have a peaceful death. But we need to understand and allow the patients, they have their own schedule, they have their own timing, and some part of it is easy to let go, but the other part is very difficult, and we could only help the patients explore what are the different areas, what are the areas that is particularly difficult for them to let go. And then another part of the treatment model that we espouse a lot of times that we because we are the professionals, we are there helping the patients, we are the experts, as if we know what will happen next. And sometimes patients would also defer to us, saying that you have seen so many deaths, you know what the process is like. You tell me what to do so that I'll die peacefully. But we could only, if the patients ask for us to share with them, our experiences, we could only share what we see for their reference, but we could not let them feel that there are certain models, certain mode of behaviors and reactions that would lead them to a good death. And patients, we need to always keep learning from the patients, even when they are dying. We need to learn for this individual patient what is, what would be helpful for them to have the death that they aspire to. Okay, and then another part of treatment model would be we have the urge to give good answers that the patient would find helpful or find satisfactory, especially questions that are related to spiritual and emotional questions. Why did this happen to me? Why do I have to die now? Can I live until a certain time? We want to give answers, but then we can never give answers that would predict a certain event, a certain outcome. So we need to remind ourselves. Patients ask different questions. Family asks different questions. It doesn't mean that we need to give them a tidy answer, or we need to give them specific answers. The questions we could take the questions as a sign, a signal telling us where the patient is at, what they're struggling with, so that we go from there, and then explore with the patients what do they really need, and the issues underneath the questions that they raise. Okay, by putting the treatment model and by taking on a more companioning model for the psychospiritual issues, we need to look at ourselves differently, and we need to. It's very difficult, but we need to accept and respect that the spiritual, emotional distress that the patient is going through, is exhibiting right in front of us, is not something that we need to get rid of or to reduce right away. But we need to look at it as part of the healing process. Part of the patient might suffer from a lot of distress, but then by expressing what's behind this distress, what are their concerns, what are most disturbing to them, then we help them to engage in the healing process, where at the end they would recognize what the process was telling them, and how they could make sense of what they are going through. And with the companioning model, we need to shift the focus a bit, with the focus away from us and back to the patient, and let the patient guide the journey, because every patient's concern is different, and we need to work closely with every patient, and then let the patient guide us of what they see as would facilitate them to go through this reconciliation process. So our role is more to facilitate the patient in this in this journey instead of sometimes we guide them, sometimes we are standing by the side and kind of keeping them company in their struggle. And the quality of care in this model is the quality of care we give is just by how well we allow the patient to guide us, that we everything starts from the patient, where the patient is at and what the struggle was about, what the disturbance, what they want to do with this disturbance. And then in this model, denial, which we encounter so much, we need to work with the patient's denial, different level of denial, with patience and compassion, because patients deny for a reason, and maybe sometimes it just is so overwhelming that the first reaction would be to not wanting to recognize the truth, and we need to understand that instead of urging the patient to go on to overcome the denial for our convenience. Okay, working on other issues with the companioning model, we need to remind ourselves that, of course, letting go, patients would feel more at ease, and they would the likelihood of experiencing peace is congruent with the level of letting go. But then letting go is, they have their own timing, they have their own readiness. The letting go is determined by the patient, but not as our agenda for them to let go before they die. And then we see patients as the experts to guide us, and there's no urgency to solve or satisfy any dilemmas, because the dilemmas has to be addressed by the patient. And then in addressing the dilemmas, the patient, they do what they feel they need to do, so that they would feel more at ease. And we could not just take away the dilemma, more at ease or more peaceful. Again, with this model, we defer to the patients for their own wisdom. The wisdom does not come from us. We could only facilitate, we could only be there to validate, to be by their side when they gain insights. But the insights is not something we give them. Okay, and then, okay, the skills we need for taking on this companioning model, because every patient is unique and different, and we only get to know the patient that much in our encounter with the patient. So we need to exercise our always very helpful active listening skills, so that emotionally patients feel that we are close to them, and that we are ready and willing to connect and learn from them. Okay, because we instead of saying a lot, giving a lot of advice, it's always very important, or most important, to exercise these active listening skills, so that we get to learn and connect with the patients. And then and because it's a process where the patients go through in the depth of their psyche, we need to exercise a lot of facilitation skills. Like we encourage the patient to explore, we encourage the patient to reflect, and then we follow their pace, and then we will not either lead them or being led. So the patient, the pacing is very important. We sometimes we need to recognize sometimes we are having our own agenda. We felt that the patient is getting weaker and weaker, and then there are still so many unresolved issues we want to push. But then that's only our agenda and our own timing. And in patients going through very difficult issues, we talk and we engage them, but at a certain point, we allow silence to take place. And we need to learn to be comfortable with silence. That's very important, because I learned that a lot of times silence is the space where changes take place, some internal changes take place during silence. And so we need to respect that, and we need to make sure that we honor this need for silence. And then it's very important for us to be comfortable with and be present with others' pain. In other words, we need to be comfortable with uncomfortable. And because we a lot of times when we are in the caregiving role, we have a sense of helplessness when we see patients suffer, and then they suffer for a long time and they struggle. But we need to know that we are not to fix them with ready-made answers. And we need to remind ourselves that disorder, confusion, messiness is the norm. And then in order to do all that, we need to be ready and willing to self-reflect, because we need to remind and be mindful of, hey, I did all that. Is it more for my own comfort or actually meeting the patient's needs? We need to be very be aware of our own behavior and the reasons behind our own behavior. Okay, in order to help us to really be able to facilitate patients going through this reconciliation, it's not about skills, it's not about techniques, it's about willing to open our hearts, going into the wilderness of the soul with another human being. And when patients are ready to invite us in, we go in there with them. Thank you.